What other type of treatment is there? And do you isolate mainly the stress or the urge? Most people have mixture, so how do we develop further and further treatment?
So we've talked some about the stress incontinence treatments, and the mainstay would be what we've talked about, the weight loss, the Kegels, and then if we get to, we have surgical correction. So for urge incontinence, most people have heard about the medicines, and there are a lot of medicines.
Are they good? Do they help?
They're good and they help. However, they have side effects, and then the disease process can progress and they stop working. And so we don't want patients to lose heart, because now we have really great advanced third-line therapies for patients that have refractory urge incontinence.
So what would be third-line treatment for refractory, people that weren't doing well?
So we have three main third-line therapies. One would be Botox, where we look in the bladder and inject Botox.
Botox
Yes.
in the bladder?
It was approved in 2013 for the refractory overactive bladder.
So what does it do? Relaxes the muscle?
Correct.
It's a skeletal muscle?
The bladder muscle is a smooth muscle.
Yeah. So it relaxes the smooth muscle also?
Correct.
And is it easy to inject
It is
Botox?
very easy to inject. We have a specialized needle, and it takes about 5 minutes to inject Botox in the bladder. We do tend to do it under twilight, so a little bit more comfortable.
Yeah, just, by twilight you mean a little bit of la-la land
You got
anesthesia.
it. You got it.
So Botox, what else?
So we have posterior tibial neurostimulation, which I tell patients is the acupuncture. We have a little needle, we put a little needle in the ankle where the posterior tibial nerve runs, and you can stimulate that nerve for 30 minutes once a week for 12 weeks, and it actually has a 65% improvement in urge incontinence.
Oh my goodness. Botox, stimulation of nerve way down in the ankle. Can you set up a wire that automatically you push a button and stimulates it?
No, one of our nurses puts in the needle, and then it's on and it stimulates it for 30 minutes.
How do you decide which one to use, Botox or the nerve stimulation?
We have a conversation with the patient. We talk about the goods and bads and uglies of all of our options, including the third, which is the interstim, or it's the sacral neuromodulation, which everybody kind of knows as the bladder pacemaker.
Okay, so it's a bladder pacemaker.
Correct.
And how do you do that?
So
you have to go in the back
that
where the
goes in the
sacral
back.
spine is?
Correct. So the sacral nerve root is what stimulates the bladder. Specifically, we're looking for the S3 nerve root. So when we stimulate that, then it puts the bladder back in the normal functioning.
So when you stimulate the S3, the third sacral nerve, or space area, how do you know you're there? How successful is it? And then I'm going to ask you how you know whether to use the Botox, what I call the ankle stimulation, or the back stimulation.
So
Everybody's different.
So the interstim is very successful. It has about 80 to 85% success rate. We know we're in the right nerve root because when we actually put it in, we use fluoro, which is an X-ray, to find the right landmarks. And then there are specific motor responses to that nerve to say we're in the right spot. So that is how we sort of decide we're in the right spot for that. How we decide between those three, it is a conversation between me and the patient. I explain what is involved with each, the goods, what is good about it, the bads, and then we sort of make a combined decision on what we think would be best for them.